This conference will now be recorded.
Hello, everyone, and welcome to our round 19 of the most successful course that we have in the MRCOG online sessions. Okay, so my dear friends, welcome to the journey. I believe that the part two MRCOG is not an easy journey for a lot of you. However, because it's the highest, certificate, the most prestigious one among all the postgraduate degrees in the obstetrician and gynecology. So we think that everybody who can make the curriculum of the MRCOG Part 2 can do any other exam based on British guideline, okay, or English guideline, including maybe the Arab board, for example, the Egyptian board, our friends who passed with flying colors from the Sudani board as well. Our friend who joined the course before and passed the MRCPI, that's because we give actually the most comprehensive, course among all. So let's see what is the plan in our course, especially the new group who are aiming for the July 2023. However, some also are aiming for January 2023, but they want to attend the early course and then after that they take their time in the revision. So it's a good idea. The most common question that people ask, how many months are required for the exam? I would say that if you are a fresh graduate or you are a beginner or this is your first time to attend international postgraduate exam, so you will need around 1 year. Okay. If you had a previous exam in the postgraduate and you have previous experience, then you need from 5 to 6 months, I think. Okay, so this is the I think the ideal time. So our course, in order to achieve the highest percentage of success as we promise and we aim, will consist of two phases. One phase is the preparation phase and one phase is the revision phase. Okay, and I'm so proudly dribbling this course for few years now, and alhamdulillah with a good success and a good repetition. And most of the people who join my course join by recommendation from friends. Okay, or they have attended the course before and for some reason they couldn't do the exam and they want to continue with me. So it's my honor actually that this is the type of candidate that we have. It's the best way of advertisement is by word of mouth. So alhamdulillah for that. My friend, there is a bit of the modification and update in this course. Okay, that's because, in the recent years, there was a huge amount of publication from the RCOG, a huge amount of update in the guidelines, also the TUG articles as well. And the recent 2 years, at least, in the TUG articles, they publish very interesting and important topics. So makes it hot. Okay, for the exam as well. So we have to update ourselves as well. Okay. Alhamdulillah, our strategy and the way of thinking and the systematic approach to the MQs and the single best answer question work very well. Okay, but we need more intense preparation. Okay, so I ask you, all of you, my champions, before we start, okay, I'll do my job, you also do your job, okay? So I'll do my job in delivering the most important point in the exam, the tricky point of the exam, the way of thinking of the RCOG, and I call it the RCOG mindset. And you also do your part, okay, by first of all, you have to believe that you can do it, okay? And you have to believe you are preparing yourself, okay, to be consultant in the future, okay, in the UK. So you have to be updated. You have to learn how to follow evidence-based recommendation. Okay, so if you didn't read the guidelines, I will advise you strongly to go through them reading at least once. Okay, and step by step you will understand how to critically thinking, okay, of the guideline. This is very important, and how to understand the level of recommendation and different level of recommendation, so in the choices you can apply the correct choice. Okay, so this is the preparation phase that will last for almost 100 days. Okay, so 100 days, that means 3 months. Yes, 3 months, me and you, my dear friends, are going to do it. Okay, all the preparation in 3 months. Yes, we will be able to do this. Okay, so session time will be longer. Okay, especially the first session during the week. This will be like around 4 hours. Okay, and the second session time will be not less than 3 hours. Okay, so means that we will take more intensive, you know, sessions, and we cover more topics in one single session. Okay, the records will be posted on the website, and the website records, you know, it's uploaded on Vimeo. Okay, so you can speed up if you want. Okay, so if you are busy working, and we expect you all are busy doctors. Okay, so if you are busy working, you will find the record within 24 hours of the session. So just listen to the record. You can speed up the record a little bit. Okay, disadvantages found, okay, on the on our recording. So that's mean you will be able to go through the session and listen to the important point. Whenever you listen to the session, I don't want you just listen. Okay, so this is not something funny or something light, or it's a talk show, so we can listen to it while we are in the kitchen or we are driving or something like that. Okay, this is up to you if you want to do this, but don't consider this as attending class. Okay, if you are attending class, then you need to be in a class. Okay, so in your office, please, with highlighter and a piece of paper, your notes, okay, and highlight with me the important point. The notes are available on the website beforehand, so that means you can print it. Okay, and this advantage we offer on the website, and most of the people, they don't want to share the material or whatever. With all due respect, I believe that according to each one's style of studying, okay, you should have the notes in hand, or at least download it. So if you are using iPad, then it's okay, available for you. If you're using a printed form and highlighter, this will be available as well. So please print it out, okay, and highlight the important point. At least if you don't want to print, take a notes, okay, and make notes, make MRCOG notes. So today I would like you, please, okay, to show me your new notes. Okay, it's like first day of school, so this is first day of classes, okay, of the course. So notes, that's very important, because each topic you have to write down the key of the topic, okay, and the tricks that Dr. Rabah will tell you for it, and whatever extra resources I would recommend, or whatever points to stress on, please do this. You know why? Because by the end of the course, you will find a huge amount of material and curriculum, the long curriculum of the RCOG, okay? So you will find yourself like, okay, and lost in between so many topics here and there. This is not how the human mind work, okay? So in order to work correctly, you need, my friends, to organize yourself, okay, and you need something like a mind map to help you, okay, and the best note is to write to yourself by your own way, okay, the important point to take off. This is what I need you to write, okay, in the notes, the important points in each topic. So if let's say today we are going to revise the screening, so I need you to write in the notes, okay, the screening, how to do the screening here, how to do the scoring system here, and blah blah blah. Okay, so this is very important. So we all please study this way. Otherwise, you will find yourself in the exam or towards the revision even, and you forgot a very basic information about this topic. That's because we had a lot of curriculum, okay? So in order to be able to continue, I need you during the preparation phase, please, to follow the advice. This is one thing. Another thing, that our sessions should start from today till the last week of April. This is the preparatory phase, okay? And this is for 100-day, okay, session. 2 sessions per week, and we said that it will be longer session, okay? And 1 TOG reading meeting. Oh God, what is this? This is a very interesting session, okay? This is for reading TOG articles. This, of course, that will be recorded, and also we will have new guideline reading sessions with me, okay? So the TOG reading meetings will be mainly divided between me and Dr. Nada. Dr. Nada, she is doing, as you know, she's doing a very great job, a brilliant job in writing summaries and helping the candidate. And also she is participating in the teaching in this course. So my dear friend, you will attend the TOG reading meeting, and this is for knowledge, okay? For the exam, we will highlight few points in each talk. Some talks are very important and need extensive, studying. Some points you just need to highlight the important points or the text here and there and finish it, okay? So the TOG reading sessions, this will be very important. So please try to attend it. And if it's not, then this one you can listen to it at any time. Also, in the updated guidelines, I will run 1 or 2 reading sessions as well, a meeting for the updated guideline, especially the NICE guideline for labor. Okay, this will be open for all. Okay, so this is my plan for the studying. I have posted the voting today on the course group, asking you guys whether would you like to start with the gynecology or the antenatal. So and now I'm looking to the result. Okay, so far people choose the antenatal care and maternal medicine. Okay, so we will respect the voting. And for our friends who are interested in the gynecology, then the TOG reading meetings and the new update will focus on the gynecology part first. Okay, so we'll make like a balance and everybody will be happy. Okay, so it is the first phase. The second phase will be the revision phase. And in the revision phase, I do really believe that the revision is very important. And if we say that we have to achieve 100% for this exam, so whatever preparation and reading and study you make, it makes 40%. Okay, so if you have read all the resources under the sky, okay, you have read every TOG article, every scientific impact paper, every guideline, every college, update, you will only be able to achieve 40% in the exam, believe me, okay? And 60% on the revision means solving questions. But I can't go for solving questions without this base of the preparation, right? It makes sense. So I should have a good base then to build on. Otherwise, solving questions, that is like you're trying to be smart or trying to have shortcuts. Okay, this will be absolutely, not recommended at all. Okay, so no shortcuts, no, please. Okay, no solving just recalls and you think that you secure the exam. Ask anybody who have attended the exam recently, and I have, 2 groups. I was running 2 groups for the part 2 January 2023. And alhamdulillah, I had a good feedback, a very good feedback from the friends that the course was very helpful to them. Just ask them, okay, how was the exam question came? Okay, so people, they tend to remember few words from a whole scenario, from 18 to 20 option in the EMQ, okay? And this is what you get. If you don't develop the critical thinking, the RCOG mindset, you will not be able, believe me, to solve the exam. People know the question, but they don't find the correct answer in the option. How? This is because it's not a game. This is the MRCOG part 2. This is what expected to be in the exam, okay? And this is our aim in the training. This is the level or the standard of teaching for this course, okay? So the revision phase, please don't come to this phase of revision if you don't have a good base, right? Please. So in order to have an effective revision. So we will start from the 1st of May, okay? And we will do a mock exams module wise, okay? And then we will have EMQ solving sessions. This is very similar to the exam EMQs. And finally, this will be some tricky recalls, okay? And you will, by attending this revision, okay, I can tell you that 95% of the exam is guaranteed. Okay, you will have experience with 95%. This is my part. Your part, okay, is that you note everything and make use of it. So it's like, guys, I give you the same standard as the exam. I give you very similar question to the exam. Okay, it's your role to solve them correct in the exam, right? So I believe in you, my friends, and I believe that you will be able to do it, inshallah. So what are the resources? Yeah, what are the resources for the MRCOG part 2? Okay, so simply the resources is the MRCOG, okay, website. This is your resource, and I don't want you, please, to jump in between here and there, okay? And even when we recommend that you read the guideline, okay, so Dr. Nada can help you with the resources of the guidelines, the PDFs and all, okay, if you want to read the original copy or to keep the original copy of the guidelines and took articles and all, okay? But our summaries are more than enough. Okay, our question bank is more than enough along with the other, point in the question bank and the verified recalls and all. Okay, so you will find that our resources, this will be, one second. This will be the main course resources, okay? Here, this is your main course resources. Okay, and this will be divided, if you have noted, divided into module wise, okay, and you will find all the modules, okay? So if we said, for example, how about the antenatal care, okay, you will find the antenatal care resources, okay? So here you will find the guideline and took articles, okay? You will find some pre-recorded sessions as well for the took articles, okay? That's very helpful, the hot topic in the maternal medicine, because it's very long. Okay, so the module of the maternal medicine is a very long one, and the antenatal care as well, and there is a lots and lots of took articles are there. So this one you can listen to it at any time. Okay, this is a part from the sessions. You can consider it as part of your resources. The all the blue icons are for record, and all the red icons are for PDFs. Okay, the PDF as I told you that. So let's, for example, okay, check this PDF one, genetic tips for the part 2. Okay, then you will find here this PDF can be downloaded. If you click here, download this file, you can download it. Okay, so I depend on you, you are adult, okay, and sensible enough, so no sharing please, but this is for yourself to study it and to print it out and to help you in your study. Okay, so this is regarding the study resources. Okay, so let's agree study resources on the website are enough and more than enough. Okay, and everything is found here. Okay, so don't worry about other resources, and all the notes are available for you. Okay, and here we are announcing soon, okay, a separate TUG article. That's because the TUG articles are growing, okay, fast. So we used to have the TUG article in the same, under the same preparatory material, okay, but then I found that it's better for our friend who are interested to listen to the TUG article itself and in details, that they can have a separate course for the TUG article. This is the MRCOG talks, okay, and this will be opening soon. That's because of the update. Okay, we are adding update here. Okay, so this one that will be opening soon. So from I think 15th of February will be available to our course candidate. Okay, plus that what we already have prepared for you. Okay, then the question bank. For the question bank, as you all know, this is our question bank. This is a module based mock test. Okay, we have lots and lots of them, and it's still updated, and we have also TUG articles mock test. Okay, and we have a final mock test, okay, as you all know, and here the final exams, and here we have also shared link. Okay, this is for another set or new TUG articles, okay, available on PDF. Okay, this is with the help of our fantastic, okay, teacher, Dr. Nada, okay, that she is have all this prepared for you, okay, to be organized, and you find all the questions, all the important question in one place. Also, the corrected or the verified recalls file also available. Okay, then we'll come to the final mega mock. Okay, and till now we have around 400 questions in this final mega mock, but it's still we're still adding to it. Okay, so this all are available for you, so I don't think that you will need any other resource to study. Okay, so let's agree that your resources and everything needed to pass this exam will be only on the MRCOG website. Okay, so our group, the Telegram group, this is for discussion, for notification, for update of the course, and for taking your opinion, okay, regarding any change in the course, like today, for example, the voting on how to start and which module to start with. Okay, are we clear so far? Any questions regarding the curriculum and regarding how to start study or how this course plan are be?
Hello, Dr. Rabah, if I may.
Hello, Dr. Nada. Yes, sure, of course, Dr. Nada,
How
you're
are you?
welcome.
I just want to welcome everyone to the course. Inshallah, it will be a very informational course for you. Just please follow Dr. Rabah's advice because she helped me a lot one day, and I want, inshallah, she is going to help you too. I just want to give you a quick feedback on last exam from our candidates. Many of them have called me and told me about their experience. In short, it was very overwhelming. Guys, the college tends to brought back the long EMQs, very long choices, like 10 to 12 choices. So it's huge, and you have to keep your what can I say it in easy words, because really I can't imagine if you have like 20 questions with those long choices. Even if you know the answer, if you are not solid in your knowledge, you are going to lose it. And that's why I'm telling you, You cannot just copy paste the question and the answer, the question and the answer. No. Try to be solid in your knowledge. Try to clear your concepts. If you feel at any point that you have conflicts between things, please ask about it. Please, especially maternal medicine and obstetrics. Many of you are used to run your job according to some guidelines. The RCOG is different and full of details, and they love to ask about those details. So please, at any point, and me and Dr. Rabah always beg you to ask about it. It's okay. We are here to help you. Answer many questions. You are going to have new ways of thinking. So you will have questions. So you are going to ask, and so on. When you don't ask, we know that you don't study. This is a fact. People who don't ask, they don't study. They don't think about what if he asked me about this? Is this related to this or not? Okay, guys, clearing concepts is the main thing that you are going to pass through this exam, inshallah. To be solid, to know the answer before even you look at the choices, because the choices are very conflicting, very conflicting. So you need to know it before you choose the choices. I can remember one last thing before I go. One of the candidates told me in exact same words. She told me at one point, I tend to close my eyes and don't look over the choices and try to memorize the correct follow-up in my mind, because whenever I look at the choices, I forget the numbers because they are very many. They are like, try to imagine 10 choices from 26 weeks to 86 weeks, then at term. From 24 to 26, then at 36, then before labor. From 24 to 28, then at 30, from 30 to 36, then after delivery. Try to imagine lines like this, 10 lines like this.
Okay.
Very exhausting. Yes, very exhausting. Thank you, Dr. Rawa.
You are welcome. Thank you very much for participating, Dr. Nada. So just want to ask you, you think that what you're saying that came in the exam is by any far similar to this, what you can see here?
Similar to the question bank. The
What you
obstetric
can
cases
see.
was just identical to the question bank.
It's
Identical.
actually, we can't say that we know what
I
came
can
exactly
say
in the
that
exam.
because I have recalls from like 5 candidates up till now, and I have combined the choices from the 5 candidates. So it looks like the exact EMQ in the question bank. Not
So
all of
let's
them, of
say,
course.
let's
Not
say,
all of them.
let's say same standard. Okay. So, and
Yeah,
this is,
yeah, you can say so.
yeah, so this is what we need, my friend. This is what we need, that you be ready for the exam standard and be trained on the same level. Okay, I have an old file that he used to share at the beginning of the course. It's about why do people fail, and in the same time I'm sharing, okay, all the my dear friends with the highest scores that joined us before, and they make us proud. Okay, and by the way, Dr. Pushpi, she's one of the candidate. I was proud one day that she was one of our candidate. She had the golden medal, okay, for the highest score on first time in the second and third part. Okay, so this is something that it's really an honor for us. Okay, so guys, you can be there. You can be there one day, and just, okay, follow the guidance and trust yourself, okay, and listen to the advices of the people who had experience before you, okay, and there is no shortcut to success. This is what I need you to know. So if we discussed why people fail, simply that's because people, they don't know the curriculum, don't know what is the required from them to cover in the exam, and the wrong resources. Maybe also they collect some resources from here and there, and some broken recalls. The recalls can be very helpful, and at the same time can be very dangerous, because it's very helpful to show you what the important topics and what is the important point that the exam focus on. But it can be very dangerous in the same because it's broken. It's not a full question. Okay, so I can't train you, actually. I can't guide you on a broken question. However, we have the complete questions, we have the comprehensive options. Okay, so you can go on that for training. Okay, so same level as the exam. We used to say for the mock test, you have to practice every day 200 question at the same level of the exam, and this means you only practice complete scenarios. Okay, that can be very helpful. The recall can be very helpful in the single best answer questions to remember some topic, can be very helpful to guide you through what is the important topic for you in the exam, but it can't be really a good way of thinking or training or a resource to study, especially for the MRCOG. Okay, so the important thing is the resources, then your ability to stick to study plan. So please, if you have some, we all face some personal circumstances, from sickness, from family things, from maybe celebrations, anything, either good or bad, make us busy, and you lose the the track of the group. Okay, and you think that it's overwhelming to go through all of this. Please don't make it long. Okay, and whatever the point you come, okay, join freshly. So let's say you are away for 2 weeks. When you come, don't try to go back to what you have missed in the 2 weeks. Just join from the point you came, okay, and continue with the group. Otherwise, if you are lagging behind for 2 weeks, these 2 weeks will make you lose the whole course. Okay, because I know people will lag behind for 2 weeks or 3 weeks. When they come back, they're trying to make what they missed, listen to the records and all. Okay, and every time they join the meeting, they think that, oh my God, we are very far, so I will continue on my own base. No, you have joined the course not to study alone, not to be in your own island alone. You join the course, then you have to follow the course, please. Okay, you join the cohort. Why? Because for some certain point, when the exam is approaching, you will feel that stress is so high, and you will lose the interest to continue, and you will lose the faith in yourself. In this case, the study group or the course is the only thing that will push you towards your aim. Okay, so my friend, the curriculum, have a look at it. I will post this file for you. Okay, what is required from you to study under each module. Okay, so let's say if you have to study the antenatal care, what is required from you? So we'll say NICE guideline, antenatal care, even at the time of COVID, this one is highlighted yellow, so this is less important than the green ones. Down syndrome screening is highlighted green, so that means it's one of the hot topics or the important topics. Genetic disease and major abnormality, this is also common. RH isoimmunization, twin pregnancy, VTE prophylaxis, air travel, and antepartum hemorrhage and abnormal placenta, small for gestational age, reduced fetal movement and IFD, large for gestational age, and polyhydramnios. This is from the hot topics of antenatal care. So because we are starting with the antenatal care, then we will have to review those topics, okay, first, and then the maternal medicine, here is the topics, and before each module we are starting, okay, then we will have a look to what is the point important in the curriculum, okay, in that module, okay, and the available resources on the website for it. Okay, and if you need any extra reading material. Okay, my friends, so this week that will be a single session, and this will aim to discuss the NICE guideline of the antenatal care update of the 2021, and it's the journey of care, or the journey of the pregnant woman in the NHS, and what they expect during the journey, and how about the high risk patient, okay, and how about optimization of each condition during the pregnancy. This is what you need to understand or you need to take care of. Okay, so the NICE guideline introduction, it's about the journey of the pregnant woman, starting from the booking till the screening, specific screening for disease, screening for the sickle cell disease and thalassemia, and then the patient will be offered, or the woman will be offered, a blood test for the Down syndrome screening and the ultrasound, which we call the combined testing, right? And also after that, the woman will have in her journey the anomaly scan. This is between 18 and 21 weeks. And after that, at the 28th, she will have the hemoglobin assessment or the antibody assessment as well, repeated, which been done at the booking. Okay, and after that also we will just follow her up according to her risk. Either a low risk patient, this will be managed in the midwifery unit, and a high risk patient, this will be guided to the consultant led care unit. Okay, so I have this light topic as a start. However, I will go through the important point for your exam through the journey. So we said the woman will start with the antenatal care journey, right? And they should have the booking visit by the 10 weeks of gestation. The statistical, result found that people who are late booking, they are having high rate of complication, and they have higher rate of developing maternal morbidity and mortality, right? Which comes in the report that we use also to study for the exam. Okay, so this is for the booking visit, and then we'll see what happened in the visit. Okay, so the first thing at the visit, that they will identify the woman at risk, right? So the woman at risk, like the woman who use the misused substance. Okay, so what is the surface that this woman should be referred to? Okay, I know this is very basic information, however, it's important for you to understand the system. Every woman start from the screening or the booking will be identified to either continue on the low risk follow-up, or the woman will be guided or referred to high risk or specialized surface. Okay, so what is the name of surface for a woman who had substance misuse in the NHS? Anybody of you can help me with this piece of information? Anybody, my friends? Anybody would like to share with me? This is just a welcome meeting.
Hello,
Yes, hello,
دكتورة
Dr. Rabia.
دكتورة
Rising.
رابع. Yes, welcome, دكتورة رابعة. Welcome everyone in the group.
Welcome
Thank
to
you
you.
for this introduction. I think this
Thank you,
is
dear.
preparation important to start in right way.
Inshallah. Inshallah.
I
Thank you, dear.
didn't hear your question, please, دكتورة رابعة. Could you repeat?
Yes, for a woman who's using illegal drugs, like the substance misuse. So what is the referral system for her? Specialist service that will help her in the NHS? Because this can be a choice for us in the exam.
I will consider, I think this is high risk pregnancy, should
Sure.
be in consultant led unit. You mean like this, or a specialized center for substance abuse?
Yes, a
You
specialized
mean?
service. Yes.
Uh,
Yeah, no problem. Just think about it.
I don't know this.
No problem, no problem, dear. I will find what's your friend. Thank you very much for sharing, Dr. Rabia. Okay, so let's have a look here. Okay. Yeah, so there is a safeguarding issue, of course, in this regard. Okay, yes. So Dr. Sophia, the social service frame, okay, it's good that you have at this point, okay? So the social service there is a service that help, you know, people in the UK, especially vulnerable people or people with disabilities or young people at risk, okay? So it is to help them in their social, okay, part of life, like ensure that they have safe place, housing, okay, they have the appropriate help in place, and they speak to other, you know, organization and take care of this person, vulnerable person, okay? But we ask here, okay, about some service, okay, like you know, the smoking cessation service, let's say, for smoking, if a woman is a smoker in pregnancy. But how about the substance abuse? This is a question. Okay, so there is a help, of course, for the drug addiction. Okay, this is a special help. Okay, and we have a drug addiction service. Okay, and there will be in every area a local support, right? A local drug treatment service for each area. Okay, so if a woman who had a substance misuse in pregnancy, she will need, as we say, MDT approach. How MDT approach? Okay, yes, it's a MDT approach because the MDT approach consists from the midwife, even the GB should be participating in this MDT, okay, and the consultant obstetrician or the specialist obstetrician, and also somebody from the addiction center. Also, social service will be involved in the care, but the social service involvement doesn't mean that I will refer the patient with drug addiction to social service for treatment. Have you got the point there? Have you got the different, Dr. Sophia? So social service is there, okay, but they don't provide treatment. Okay. Okay, so the drug misuse in pregnancy, this is one of our topic that we will discuss, and I can send you some interesting document to read, okay, in order to understand what is the pathway for care in the pregnancy for a woman who's using illegal drug, okay, and what can we offer her as well, because let's say we will not report that to the police, right? We want to help them go through this and reduce the health risk from having misuse in the pregnancy, okay? So this is one of the things that will come in our antenatal care, okay? So the woman who had risk like misuse, she will be referred to the appropriate service, okay? And especially the recent migrant, asylum seeker or refugee, those will have difficulty in communication because of the language barrier, and also they can have social help and support that because they have problems, okay, in you know, in settlement in the UK, so they need help as well. They need extra help. Women under the age of 20, okay, and we have for the teenager pregnancy, we have a specialist clinic, my friend, for teenager pregnancy, and there will be a specialist midwife to take care of pregnancies below the 20. And the most important thing is that we ensure the health of the mother. We want to ensure also that her life or her social circumstances is not affected by the pregnancy. She have a safe place to live in, and she can afford taking care of this baby, okay, and in the same time she can continue her education because she is still under 20, right? So women who experience domestic violence, of course, there is a lot of help in place, okay, like the MRCOG for the women who are having domestic violence, some organization like Women's Aid, Refugees, okay, so this is also to help women who had the domestic violence. So those things we need to explore when the woman comes to us in a booking visit, and we need to understand where to send this patient for care. Okay, so it's this part is all of the system in the NHS. This part is particularly important in the part 3. However, you will have question on it in part 2, and if you don't know or you're not familiar with the system, this will be a complete, mess for you in the exam. Here there is a question from the MPRACE report, which came in the guideline, the 2020 MPRACE report, which have found that the maternal death during pregnancy up to 6 weeks, okay, rate is higher in Black women, up to 4 times, and 3 times in women with mixed ethnic background, 2 times higher in Asian women. And for the babies, the stillbirth rate is also more than twice in Black babies. This question came in the exam. Okay, so the information here and here, okay, about the death rate in mothers and death rate, neonatal deaths in neonate are important in your exam to know what is the numbers. Okay, that's important. Okay, also they have found that there is disadvantage also by living in deprived area, so increase also neonatal death and maternal death as well. Okay, and the stillbirth rate increase according to the level of deprivation in the area where the mother lives in, with almost twice as many stillbirths for women living in the most deprived area. Okay, so by living in deprived area, how many times the risk increase? Question is easy so far. Hello, my friend. 2 times, 3 times, 4 times by living in deprived area. Chat box can help you. Okay, so you can type on the chat box your answer. That's very quick and easy. So for deprived area, neonatal stillbirth rate is twice. Okay, for neonatal death or stillbirth rate, okay, we find that twice for the Black babies and twice for deprived area. For the maternal death, if they are in deprived area, this is 2.5. If they are Black, this is 4 times. Yeah, so I'll tell you, dear, okay? I'll tell you, okay? Areas, Dr. Noha, if you have a deprived area, this is mean that it's area with people who have lower socioeconomic, okay, and they require more of the attention of the government, okay, to help them with service. However, lately, due to the economic problems, COVID and all, okay, there have been some shortage in this area in delivering proper care to this woman. So they are suffering from socioeconomic problem, and also the government or the the fund of the government is reduced, and then because of the shortage, over the last few years, there's so many problems in the financial issues and all. Okay, so deprived area now, they suffer more from other areas. Okay, this is the thing. So deprived area, no matter it's people who are living in the deprived area, either white, from European origin, from Asian origin, from Black background. This is their socioeconomic level, okay? But the ethnicity is different. So people can have, and this is because of genes, okay? It's not because of the socioeconomic level. So Black people can be very rich, right? Okay, can be billionaires, but still their genes put them at higher risk of complication during pregnancy. Got my point, Dee? So the ethnicity background, this is something about genes. Living in which area, this is something regarding the socioeconomic facts. Okay, you are welcome. So please, guys, please have a look here to the maternal death rate, okay, according to ethnicity or according to the living area or the level of the socioeconomic, and also have a look to the stillbirth because they asked these questions before in the exam. Okay, so then we have to have a look in that booking visit about the smoking, and we advise that the woman, of course, she need to stop or quit smoking, and there is special service for smoking, and this is called the smoking cessation service simply, okay, or the NHS stop smoking service. So if the woman or her partner smoke, okay, they will be advised to stop smoking within the past 2 weeks. Also, they will be referred. Ask the woman about the domestic violence and FGM. Of course, this is in kind way, and this is for the high risk groups, okay, especially domestic abuse. This is for everyone, but however, also there is some areas on some certain ethnicity with higher rate of domestic violence, but this is risk, unfortunately, for every woman in the UK. This is like a pandemic, the domestic violence. FGM as well, okay. This is especially if she came from one of the countries that known to have high rate of FGM, okay, like Somalia, for example. They will be asked in a sensitive way about if they have undergone FGM or not, and their data must be recorded according to the HSCIC, okay. So the data for the FGM, and this should be anonymized or without anonymization. Woman name will be written and documented or without that. Without anonymization. For every sensitive issues, we tell the woman that we are going to keep her identity covered, okay. But in the FGM, in the record, okay, of the FGM cases, it has to be without anonymization. This is to avoid replication. So because a woman, every time she presents to her doctor, okay, she will record that she had the FGM, okay. So every time if it is documented as anonymous, that means it will be duplication of data, okay. So that's why the name must be written in the data according to the HCIC, okay. So my friend, then what is the examination and the investigations required? Okay, so the screening for blood test is a very famous one. Every woman will have tested for the blood count, blood group, and the antibodies as well. Okay, this will be done at the booking visit, and if it's all normal, even we will repeat them again at the 28 weeks. The NHS infectious disease in pregnancy, like screening program, HIV, syphilis, and hepatitis B, this will be done as well. You will still have questions in this regard. So they will ask you, for example, all the women in the UK, they will have during the booking visit test for rubella. So what is it? What do you think, true or false? True or false? it's false. Okay, we are no longer testing for rubella. Okay, so sickle cell disease, and yes, excellent. So it's HIV, syphilis, and hepatitis B. A test for sickle cell disease or thalassemia can be offered as a screening. So the question now, are we testing everybody for the sickle cell disease and thalassemia in the UK? Yes or not? True or false? Everybody testing for sickle cell disease and thalassemia? No. Well done. So yes, for the sickle cell disease, we have to identify the woman at risk of having the gene of the sickle cell disease. Okay, so that's mean by the questionnaire. Okay, so what is this questionnaire story? So simply, they will see the family origin questionnaire. Okay, and there's some certain area where the sickle cell disease prevalence is very high or high even. Then if the woman is from such area, then we have to test her. Okay, so first is the questionnaire, then the testing for the woman, and then we will continue on the screening program, and I will show you what is the pathway for that. Then we will have also thalassemia screening. Thalassemia screening is very easy, so that's why it's offered as part of the screening. How? Because simply we look to the full blood count result. Okay, so by only the full blood count, we can identify if the woman is a thalassemia trait or a carrier for the thalassemia gene or not. Okay, so let's have a look what we can do in the thalassemia, the pathway, because it's a very common question to be asked. And the thalassemia and sickle cell disease, both are now important in the question of screening for the antenatal care. So screening for sickle cell disease, simply number one is in the step is family origin questionnaire. If the family origin questionnaire show that there is high risk of having the sickle cell disease, then the woman will be tested by HBLC. Okay, the HBLC, this is a test of choice to find out if the woman is a carrier or not. Right? Okay, so what its HPCL-BLC is referred to? The abbreviation of liquid chromatography liquid. Okay. High performance liquid chromatography. Yes. Okay, so this test name the high performance liquid chromatography test will come in the exam in the options of the MRCOG, so you have to choose it correctly. If the woman found to be carrier, what will be the next step? You will have to test the partner or the father of child, right? So why? Because simply the mode of inheritance of the sickle cell disease is recessive or dominant. This is a recessive, so you need two carrier in order to have affected child. If the woman only is a carrier and father is healthy, then the child is not at risk of having the disease, right? So we test the father. This is the next step. So first step is the family origin questionnaire, identify the high-risk woman, then do the HBLC. If the HBLC identifies that the woman is a carrier, then we need to test the father, right? Okay.
دكتورة
So
رابعة.
yes, Dr.
Sorry,
Rabia.
دكتورة رابعة. The meaning of family origin questionnaire, this is history. You mean history?
Yes, it is a history, you know, a special questionnaire. All the midwife during the booking, they will have this, and they will decide about the woman. They will ask the woman about her family origin, about which area she came from, about the father also, okay, from where he came and all. Sometimes the woman will give a clear history of not being from a high risk area, okay, and some will give mixed okay, origin. So in this case, we will test the hair, okay, and some will give a clear history that they come, for example, from a Mediterranean area, okay. So that will be according to it. To the aim of the family history questionnaire, okay, is an integral part actually of the antenatal care screening, and its aim to identify the population group at the highest risk of the sickle cell disease, and also thalassemia, and not only thalassemia or sickle cell disease. Some areas also they are known, or some also ethnicities are known to have high risk, like for example the Jewish, the Ashkenaz Jewish, they also have, you know, higher risk or tendency, genetic tendency for other hemoglobin variant. Okay, so we test them for that. Have you got the point? So it's not only for the sickle cell disease or for the thalassemia. This is by identifying the family origin and the ethnicity background, we can identify which group of disease this woman at risk or the unborn baby is at risk of. Okay, but because we test or we screen for the thalassemia, it comes by the thalassemia here. Okay, the most common, we mention it with the thalassemia. Okay. Okay, so then test further, and if the woman want to make sure that the baby is affected or not, what will be the mode of testing to ensure that the baby is affected or not? Will be the prenatal diagnostic test. This came in the guideline, and it's more clear in the TUG article, right? Okay, so yes, the invasive testing is the correct way of testing for the sickle cell disease, if the baby have the sickle cell disease or not. Okay, so in the exam they usually ask the very famous question. The question says, the woman refused the invasive testing. Okay, father is not known. Okay, and the woman, she doesn't want to have an invasive test. Then what we will do for her? No, not cell-free fetal DNA. So I have to read the guideline and the TUG article to make sure that there is no mention for the free DNA. Okay. So guys, it's under development, and there's no mention for the cell-free fetal DNA as diagnosis for the sickle cell disease in the guideline. And now it's clear in the TUG article, it's mentioned in the TUG article clearly that it's to do the neonatal Hill prick test, okay, the neonatal blood test, blood spot test. Okay, so everybody when they're born, every baby in the UK, they will have by few days after delivery, this is up to day 5 postnatal, they will have the neonatal testing. Okay, it's a blood spot, everybody's aware, and this blood spot test, okay, they will be tested for a range of disease, okay, hereditary disease, including metabolic disorder and including sickle disease. Okay, so if the neonate is going to be tested, okay, after delivery, so why should I do the non-invasive prenatal testing? And by the way, it's not that much sensitive to ensure in the condition of the sickle cell disease. Okay, it's a very common mistake. Actually, that's why I'd like to, guys, ask you to follow the evidence for that. I'll post for you a screenshot from the TUG article, especially TUG article is recent, when they say that go to the neonatal screening. Okay, and this is all the time I'm saying that, because this is not the practice in the UK. No cell-free fetal DNA to test for the neonate, for the fetus in cases of sickle cell disease. We use the cell-free fetal DNA in other occasions, like, for example, Down syndrome screening, and in this case we call this is non-invasive prenatal testing because it's highly sensitive, so we use it in this regard. We can use it to identify the gender of the baby, okay? So to know boy or girl, this is to help us for some conditions, like for example, X-linked condition, like the hemophilia, okay? So if you want to know if the baby is a boy or a girl, okay, simply you can run the non-invasive prenatal diagnostic test, in this case by the cell-free fetal DNA, and find out. We can use it in the cases of anti-D, okay? This is also very important because anti-D, very important during the antenatal period to know if the baby is positive, so it will be at risk of hemolytic disease of the newborn, or the baby is negative, so you will be reassured that the baby is not at risk. Okay, so that's very important to identify. Okay, guys, but not in the sickle cell disease. We offer the thalassemia screening to all the pregnant women in the UK, and this is simply by the full blood count, by looking to the MCH value. Okay, so the MCH value, this is if it is found to be less than 27 picogram, so we will do the HPLC, okay, and if the carrier status identified, then we test the father, and if the father is positive, then mean a carrier. That's mean we want to ensure the fetal diagnosis by doing a prenatal invasive testing. This is if they know, if they want to know, Dr. Rabia, but the case of the neonatal blood test, this is only if the mother is not interested to have an invasive test. She's afraid to do the invasive test, or she doesn't want it, okay? So if the woman is not willing to do invasive test to identify if the baby have the condition or not, okay? So the technology of the cell-free fetal DNA to test for the sickle cell disease is not well developed yet, okay? It's not applicable, it's in the research stage, okay? So we don't have another way to know. But normal pathway for parent is prenatal invasive testing. So another question that come, they want to test your knowledge of the pre-implantation genetic diagnosis. And the pre-implantation genetic diagnosis is something that we can offer pre-conception, before the woman comes to the antenatal, of course, before she become pregnant. This is for the woman who know her disease. She, for example, sickle cell disease, or she's a carrier, her partner is the same carrier, for example, so she want to avoid having a baby with that disease. So in the planning, in the pre-pregnancy phase, she can have a counseling with the obstetrician, and what we can offer her. What we can offer this lady if she comes in the pre-pregnancy phase. This is a pre-implantation genetic diagnosis, right? So the pre-implantation genetic diagnosis is the correct answer for the pre-conception phase. So remember, the P was P. Pre-implantation, pre-conception, or pre-pregnancy means pre-implantation genetic diagnosis. And this is applied to all the disease that carry risk of inheritance to the fetus, okay? So this will be funded by the NHS. They will have, list of the disease, okay? And for example, cystic fibrosis, for example, sickle cell disease, for example, thalassemia, okay? And they will do a referral to the both partners to have this therapy on the NHS. This is to avoid having a baby with a disease. Some parents, they don't want this, They don't want to go on the waiting list for the pre-genetic diagnosis testing, or they don't want the IVF, because of course, if we will do implantation implantation genetic diagnosis, this would be by the IVF only. Okay, so they don't want this. They want to take their chances. Okay, so it will be up to them. Okay, so guys, this is the pathway. Yes, excellent, Dr. Rabia, good notice. Okay, this is the pathway for the screening of the sickle cell disease and the thalassemia. Then, my friends, we will have other conditions to be screened for, like assessing the risk of preeclampsia and monitoring of the blood pressure. So the woman who find to be a high risk for developing preeclampsia, this woman simply will start to receive a special care, and we can offer her the aspirin, okay, 150. Still, that's why I wrote 75 to 150. Still, in some questions on the older style, you can find this number, okay, 75 to 150 milligram of aspirin, okay, from the 12 weeks until the birth of the baby. And what will be the aim? Because this is a question, this is an exam question. What you can do to reduce the risk of preeclampsia in this patient, and he will give you the criteria of the patient, and this criteria is high risk for developing preeclampsia in pregnancy. So simply you will choose the aspirin. Some other exam question, they will ask, what is the benefit of the aspirin, okay, from 12 weeks in this patient? So the highest benefit is not to reduce the risk of thrombosis. The highest benefit is to reduce the risk of preeclampsia, because we use aspirin for different indications, like to prevent a small for gestation age from 16 weeks. We can use aspirin in the cases of antiphospholipid syndrome, for example, along with the heparin. However, the main advantage is to reduce the risk of preeclampsia. Okay, so easy question, still people can answer it wrong. My friends, what is the identification of the woman who had high risk for preeclampsia? Simply, we have two types of risk, either high risk or intermediate risk. And a woman need one high risk out of these, or need two out of the moderate risk list. One of this high risk list, what is the high risk list? Hypertensive disease during previous pregnancy. So high risk of any condition in the previous history of the same condition. Chronic kidney disease, autoimmune disease such as systemic lupus or antiphospholipid syndrome, type 1 or type 2 diabetes, chronic hypertension. Okay, so what we will do for them, we will give the aspirin. Okay, so what are the moderate risk factors? Moderate risk factor like first pregnancy, age 40 or older, pregnancy interval more than 10 years, body mass index of 35 or more, and family history of preeclampsia, multifetal pregnancy. Okay, so this is two moderate risk factor for the preeclampsia. We need two of them in order to start the woman on the aspirin. Okay, my friend, are we clear so far? The guidelines also tell us to offer assessment for the small for gestational age at booking and again in the second trimester. We will follow the RCOG and the assessment of risk, okay, minor risk factor or major risk factor. List of the minor risk factor are given: maternal age 35 or more, IVF singleton pregnancy, nulliparity, BMI less than 20, BMI 25, 34, smoker 1 to 10, low fruit intake, previous preeclampsia, pregnancy interval less than 6 months or pregnancy interval 6 months or more. So what if the woman had one of these minor risk factor? The woman needs 3 of the minor risk factor, okay, in order to receive aspirin, okay, and to have a Doppler assessment, okay, and then a serial gross scan if we found that the baby is small. But from the major risk factor list, she will need only one. Okay, one risk factor is a major one, is enough to start this pathway. So this is a list of the major risk factor. We are going to discuss a small for gestational age in detail, okay, but this introduction is to show you how we do the assessment of risk, okay, in the booking visit for the patient, okay. This is assessment of the venous thromboembolism, okay. Yes, Dr. Rawia, if there is a need for that, then we have to do it, okay? There is a need, so simply just follow the guideline, even in your practice, okay? So apply it on your practice. Identify high-risk woman and woman with two moderate risk, then start on the aspirin. The risk of the VTE, okay, so I know that it's a headache for a lot of you, my friend in the study. So simply in the antenatal assessment risk, so there is a scoring system that we have to follow, okay, and the simple equation say if the woman had total score of 4 or more, that's mean she will be high risk and will require antenatal prophylaxis with the low molecular weight heparin. If the woman had total score of 3, then she will be at intermediate risk and start low molecular weight heparin from 28 weeks until postpartum 6 weeks. And a woman had 2 only, she will be for the postnatal prophylaxis, and we will only advise, you know, mobility and all. Okay, so counting the risk factor for the VTE is a separate guideline as well. Okay, so just to know that we start VTE risk assessment from booking, okay, and we follow the RCOG in this. Even a lot of hospitals, they print the RCOG scoring tables, okay, and they, you know, put it in the pregnancy book, okay, the follow-up book of the patient. So simply at each trimester, they repeat the risk assessment by looking to the table, okay, the score, because I know it's difficult to remember all of it, but for the exam, it's a must to do. Okay, then let's have a look to the gestational diabetes risk, okay. The gestational diabetes risk, this is very important because some women will have a screening at the booking. Some women, their screening will be only at the second trimester between 28 and 24 to 28. Some women will not have a screening for gestational diabetes. Okay, so again, this will be according to the background risk. Very common exam question. So number 1, which patient that you will advise screening at booking? Patients who have gestational diabetes in a previous pregnancy, we will offer early self-monitoring of the blood glucose or OGTT. Okay, so the woman who had previous GDM, okay, will be offered 1 out of 2. 1 out of 2. What is the 1 out of 2? It's early self-monitoring of the blood glucose, and usually this will be for 1 week. She will have a blood sugar profile because she had learned it in the previous pregnancy, right? So she will do it and provide it to her midwife, okay? Or otherwise we can do the OGTT. If it comes normal, then we will repeat it in the second trimester, okay? So if it's normal at booking for a woman with previous GDM, then it will be repeated in the second trimester. Okay, so this is for the very high risk. Let's say this is a woman with very high risk. How about high risk women that require OGTT? Okay, this is either BMI 30 or more, previous macrosomic baby 4.5 or more, previous gestational diabetes, but no, it should be here, okay, or I will say here family history, okay, only family history of diabetes for first degree with diabetes and ethnicity with high prevalence of diabetes. Okay, so a woman, for example, came from the Middle East. Middle East is known to be high risk of diabetes. What we will do for her? What's your advice? Simply is a OGTT between 24 and 28 weeks. Are we clear so far, my friend? I hope that you have found this introduction meeting helpful to all of you. And I know it was like a discussion, okay, or a storytelling more than a guideline discussion. In our next session, this will be the Down syndrome screening in singleton pregnancy and twin, non-invasive prenatal testing, and twin pregnancy guideline, both from the GTG and from the NICE guideline. Okay, so we will be updated on the group, on the Telegram group. Second session voting will be also started today. Thank you very much for participating in the voting, and also the schedule will be posted since we were waiting your choices or your own preferences, guys. Remember, your opinion is counting to us, okay? It really counts and it really matters. So please participate, don't be just silent, okay? Participate actively and enjoy the journey. Thank you very much, guys, and see you next session. Thank you.